All right. Well, good evening, everyone. Good morning from Houston. My name is Caitlin Furman, and I am the Director of Education and Training for Houston Methodist Global Healthcare Services. And it is my great honor to welcome each of you to today's session. As we begin our session today, I wanted to extend a special thank you to Rofaida Women's Health Organization for the opportunity to collaborate on this webinar series. Houston Methodist and Rofaida have a longstanding partnership that really is a testament to our joint commitment to sharing international best practices with our esteemed colleagues in the kingdom. So thank you all for this opportunity and chance to highlight Dr. Ramirez and his work today. So in addition to welcoming you all, I also have the distinct privilege of introducing Dr. Ramirez. Dr. Ramirez is a distinguished leader in the field of gynecologic oncology. He serves as the chairman of Obstetrics and Gynecology here at Houston Methodist Hospital and is also a professor of gynecologic oncology. He completed his residency at Columbia Presbyterian Medical Center in New York City, and then a fellowship at MD Anderson Cancer Center, where he served on the faculty for 25 years before joining Houston Methodist. So Dr. Ramirez is renowned for his groundbreaking research, and notably as the principal investigator of the LAC trial, which he will share more with you about today. So we're so fortunate to have him with us to share his expertise. As we go throughout the session today, please don't hesitate. Down in the bottom, you should see a Q&A or a chat function. Please feel free to drop questions into that. Myself and my colleagues will be monitoring that, and we'll save some time at the end to address those. So with that, Dr. Ramirez, I will turn it over to you.
Well, Caitlin, thank you so much for that introduction. Very kind introduction. Of course, always is an extreme honor and pleasure to speak about gynecologic oncology, to host this type of event. And I want to thank Caitlin and our global team for their continued support of our program. We're extremely proud to be part of this team at Houston Methodist. I also want to recognize Rofaida for their opportunity to share information between our respective institutions. So it really is it's an honor to have been invited. As Caitlin mentioned, I'm a gynecologic oncologist, and here in the United States, gynecologic oncologists serve the role of surgeon or primarily focus on medical therapeutics, or actually the role of both. I generally, through the course of my career, have tended to focus more on the surgical component and the research component. But I wanted to do is to share with you what we consider have been some of the most impacting studies in the field of gynecologic oncology over the past decade. And certainly, I think that we all recognize, those of us who treat women's cancers, that we really have made substantial advances in the last 10 years, not just in terms of surgical trials and innovation, but also, and primarily, I would say, in terms of medical therapeutics. Really very impacting changes that are now translating into longer survival for our patients, and really just overall better quality of life in many settings for our patients, not just in the United States, but certainly globally as well. And of course, obviously, now we are contending with how do we propagate some of these novel advances in novel therapeutics to low and middle income countries as well. So certainly would love to hear some of your thoughts, and certainly we'll be very happy to address any questions that you might have at the completion of my presentation. So as I mentioned, my objectives are going to be provide just an overview without getting into the specific details of each of these trials, but providing a setting where how these trials have changed our practice in gynecologic oncology, focusing both, again, on the practice-changing surgical trials and the innovations in targeted therapy. And as I mentioned, this is an overview of what I think are the key trials in gynecologic oncology. Some of you might say, well, perhaps we didn't address this one particular trial or that other trial. Obviously, it would be impossible to, within the realm of 1 hour, encompass every single trial that has in some way impacted our field. So with that, I thought that we would target each specific disease sites in gynecologic oncology, focusing on cervical cancer, uterine cancer, and then ovarian cancer. And within each of those areas, to highlight the surgical trials and then also the therapeutic trials, both in the upfront setting and in the advanced stage disease. So with that, of course, in cervical cancer, as Caitlin mentioned, the LAC trial was one of the, I think, most impacting trials in the last 10 years. And certainly I was very fortunate to lead that trial. And this trial came at a time when we in gynecologic oncology were adapting minimally invasive surgery as a standard approach for patients with endometrial cancer. But obviously then the question came with regards to, should we evaluate whether the surgical approach impacts oncologic outcomes in patients with cervical cancer? And why so? Well, because we felt that in cervical cancer, the disease process, the disease biology is very different than in endometrial cancer. In cervical cancer, the anatomy of the malignancy is different. As you know, in endometrial cancer, obviously the disease is confined often to the lining of the uterus or within the uterine body, as opposed to cervical cancer, where we actually, of course, have an exposed tumor, a gross tumor. And then we felt that we needed to evaluate this question. And frankly, our expectation was that similar to the endometrial cancer trials, where there was no difference between open or minimally invasive in terms of oncologic outcomes, we were expecting that likely that was going to be the case. But much to our surprise, in the LAC trial, after 631 patients of the projected 740 patients, we learned from the Data Safety Monitoring Committee that we needed to close the trial because the rates of recurrences were 4 times higher in minimally invasive surgery compared to open surgery. And certainly the overall survival also appeared that was worse with minimally invasive surgery compared to open surgery. So that was certainly a landmark moment. And of course, obviously, from that trial, we also evaluated other elements in terms of the comparison, the complications. Up until the time of the LAC trial, it was felt that minimally invasive surgery was associated with lower complications compared to open surgery. And in fact, in this prospective evaluation of complications, we found that there was no difference between minimally invasive surgery and open surgery as it pertains to global complications, overall complications. Now, some might say, well, how can you say that there is no difference in terms of complications in a minimally invasive patient? As an example, wound complications. And yes, there were 2 complications where there was a difference. Wound complications was one of them. Higher rates in patients who had open surgery versus patients who have minimally invasive surgery. The other complication where there was a difference is vaginal vault separation. So that was more common in minimally invasive surgery as opposed to open surgery. But every other complication was exactly the same. Quality of life is another component that we evaluated. And as I mentioned, this is the publication on complications. And quality of life was another component that we evaluated. And this was the first prospective evaluation on quality of life. And what we found was that there was no difference between open and minimally invasive surgery when we looked at a number of parameters pertaining to quality of life in our patients. One of the things that we did learn was that in patients who had a complication, their quality of life was worse, as one would anticipate. But if the patients did not have a complication, the open approach versus the minimally invasive approach showed very consistent quality of life outcomes. So from these 3 studies, we knew that the recurrence rates were higher and the disease-free survival was lower for minimally invasive radical hysterectomy when comparing to the open surgery, and that the postoperative quality of life was similar and the complication rates were similar. So then, therefore, when looking at the management of patients with early cervical cancer having a radical hysterectomy, number of guidelines actually changed to make the recommendation that the standard approach for radical hysterectomy should be open abdominal radical hysterectomy. And it wasn't just the NCCN guidelines. There were a number of other guidelines that actually quickly thereafter changed their recommendation. And today, the standard remains open radical hysterectomy, secondary to the results of the LAC trial. Granted, there are a number of other studies that are actually exploring, with some modifications, the same question, looking at robotic surgery versus open surgery, but we don't have the results of those studies. And certainly we are anxiously awaiting those results to see if there is consistency in the findings or if there is no difference based on the modifications that have been made to the surgical approach. So certainly this was one of the landmark studies in cervical cancer. Now, one of the things that always came up with regards to the LAC trial was, if you followed all patients longer, would you still see the same results? And this was a recent publication that we had in the Journal of Clinical Oncology doing exactly that. This is the overall final survival analysis of the LAC trial after 4.5 years of follow-up in all patients who were eligible for follow-up. And what we found was that the results remain consistent. The results remain that the recurrence rates were 4 times higher in minimally invasive surgery compared to open surgery, disease-specific survival worse with minimally invasive, regional recurrence and local recurrence worse with minimally invasive surgery. One of the things also that we found was that in patients who had no cone biopsy, in other words, patients with large gross tumors, this higher recurrence rate was more significant in the minimally invasive group as opposed to the open group. So as you can see here, tumors greater than 2 centimeters, those are the patients that have the worst outcomes if the surgery is performed through a minimally invasive approach. And one of the other things that we looked at was, what is the recurrence rate in the minimally invasive group as it pertains to carcinomatosis recurrences? And what we found was that the rate of manifestation of a recurrence as carcinomatosis was 0% for open surgery, but 26% for minimally invasive surgery, again suggesting a worse outcome oncologically in those patients. Now, beyond the question of radical hysterectomy, what about what has happened for smaller tumors, tumors that are less aggressive, lower risk tumors? So there were 3 studies, the CONSERVE trial, GOG 278, and the SHAPE trial that looked at this question. In other words, are we doing too much surgery when doing radical hysterectomy on these patients with very low risk tumors? This was the first study that we initiated actually out of MD Anderson. It was the CONSERVE trial. And the CONSERVE trial was not a randomized trial. This was a prospective trial evaluating low risk early stage cervical cancer patients. This is a population of patients where it was all grade squamous cell carcinomas, grade 1, grade 2, adenocarcinomas, and tumors less than 2 centimeters. If the patients were interested in future fertility, they underwent a cone and sentinel lymph node assessment or lymphadenectomy. If the patients were not interested in future fertility, they underwent a hysterectomy and sentinel lymph node or lymphadenectomy. And what we wanted to look at is feasibility of the conservative approach and also looking at secondarily recurrence rates in this setting. And what that study showed was that in this low risk population, patients who had a hysterectomy and lymph node assessment, their recurrence rate was 0. So in other words, suggesting that perhaps a radical hysterectomy was too much surgery for these patients. And this was the first study that suggested that perhaps patients with these lower risk tumors that could potentially benefit from a lower morbidity procedure as a cone or a simple hysterectomy. So this is the conclusion from this study, that basically in patients who had a cone, recurrence rate was 3.5%, but if you had a hysterectomy, the recurrence rate was 0%, and therefore suggesting that we should move forward and explore this further. This was another study, GOG 278, which is exactly the same concept. Patients on GOG 278 were evaluated on quality of life in addition to the oncologic outcome. So again, patients who had a simple hysterectomy, patients who had a cone, and they basically were evaluated on quality of life. And what was found was that the quality of life in these patients having these procedures was actually quite favorable. There was no compromise to all of these parameters, such as bladder function, bowel function, sexual function. There was a decline within 6 weeks of surgery, but then a return to baseline as well. But overall quality of life seemed to also be very favorable in this patient population. Out of GOG 278, there was also an evaluation for oncologic outcomes. And in that study, they basically showed that when looking at a more conservative approach, again, these are patients who are having either a cone biopsy or a simple hysterectomy, the oncologic outcome was very safe. And interestingly, again, consistent with the CONSERVE trial, GOG 278 showed that if you had a simple hysterectomy, the recurrence rate was 0. If you had a cone, recurrence rate was 4.2%, very similar to the 3.5% that was documented for the CONSERVE trial. So again, these are two studies that are suggesting we should move towards de-escalation of the surgical approach to patients with cervical cancer. But many questioned and said, well, these are not prospective randomized trial, which is obviously the ideal study to demonstrate if there is, in fact, no difference. So that's when the third study came out. That was the SHAPE trial. And the SHAPE trial was published recently in the New England Journal of Medicine. And this was a prospective randomized trial, again, in low-risk patients, less than 10 millimeters of stromal invasion, less than 50% invasion on MRI, less than 2 centimeters. These are squamous cell carcinomas, adenocarcinomas, or adenosquamous carcinomas. And these patients were randomized 1-to-1 to either radical hysterectomy or simple hysterectomy. And what was found, as expected, was that the recurrence rate was going to be very low, but also, most importantly, was that simple hysterectomy offered similar oncologic outcomes as a radical hysterectomy. So in other words, we were doing too much surgery for these patients and potentially exposing the patients to a higher risk of complications. So then, therefore, this was the definitive study that said in this patient population, we can then potentially do just a simple hysterectomy. And as you can see here, this is the stratification by pelvic recurrence rates, which were exceedingly low. And then also the death rates from cervical cancer, also very, very low in patients undergoing a simple hysterectomy. As you see here, just about approximately 1% of patients dying from cervical cancer when undergoing a simple hysterectomy. So then that takes us to the more locally advanced disease. So we have just covered early stage surgical patients. What about patients who are not surgical patients? The patients with locally advanced cervical cancer, traditionally treated with chemotherapy and radiation. However, one of the questions that has come up is, what about if, in addition to the chemotherapy and radiation, if we give just more chemotherapy, that perhaps that will further impact the outcome for these patients? And this was the Outback trial that looked at patients high risk 1B1 with lymph nodes or 1B2 and above, and they were randomized to standard concurrent chemoradiation versus concurrent chemoradiation followed by additional treatment in the form of platinum and paclitaxel. And what that study showed was that by adding additional chemotherapy, there was no benefit in that patient population. So therefore, the standard at that point from the Outback trial was that we would continue with chemo radiation alone, and of course, obviously focusing on the appropriate chemotherapy and appropriate radiation. One of the other questions that came up was, well, what about if we actually give chemotherapy first prior to the chemoradiation? So what is called induction chemotherapy followed by standard chemoradiotherapy. And that was the Interlace trial published last year in the journal Lancet. Interestingly, in that study, they showed that the induction chemotherapy arm was actually better in terms of outcomes for these patients on progression-free survival. But one of the things that has been an issue with the studies, there's been a lot of criticism with regards to the type of radiation therapy that was given, the quality of the radiation therapy that was given. There was not the current standards of the novel radiation therapy that is typically used. Also, the patient population is typically not the patient population that one would see in terms of patients that are locally advanced cervix cancer. So again, what this trial and what we get out of this trial is that if a patient is going to have a delay in getting onto the standard chemoradiation, certainly the induction chemotherapy is certainly of value. But if the patient has immediate access to chemoradiation, then typically that should not be the recommendation in terms of induction chemotherapy, and the patient should go straight into chemoradiation. And then more recently, of course, the Keynote A18 trial by Keta LaRusso that adds a novel therapy, adds immunotherapy into its standard recommendation. And this trial was a trial where patients were undergoing treatment with chemotherapy and radiation, and then followed with pembrolizumab versus placebo. And what was found was that patients that had pembrolizumab had a significant improvement in progression-free survival, and certainly an overall survival advantage. So then now the standard recommendation for our patients with locally advanced cancer is to provide the standard chemoradiation plus continuation of pembrolizumab. Now, in locally advanced cancer, one of the other questions that often comes up, and particularly internationally, not so much in the United States, but particularly internationally, is should we surgically stage locally advanced patients? In other words, should we do a periodic retroperitoneal lymph node dissection so that we can evaluate the field of radiation in these patients? And the answer is no. The Uterus 11 study was a randomized study that basically looked at outcomes based on the standard approach, which is the imaging-based approach, versus the surgical approach. And that study found that there was no difference between those patients that had planning by standard approach versus planning based on the surgical findings. And therefore, today, the retroperitoneal periodic lymphadenectomy, it is rarely done in any setting. Now, for patients who have recurrent cervical cancer, I think certainly this is where many innovations have come out in the last several years. Of course, GOG 240, studied by Krish Tiwari, was the study that was a key study in introducing bevacizumab in the treatment of patients with recurrent or metastatic cervical cancer. As you know, this was a study of 5 arms where there were 2 arms that, I'm sorry, 4 arms. There were 2 arms that had chemotherapy alone and 2 arms that had chemotherapy plus bevacizumab. And in that study, what was found was that there was certainly an improvement in the progression-free survival, and there is an improvement in the overall survival with chemotherapy plus bevacizumab. And again, of course, obviously then highlighting that this should be the new standard moving forward for patients with recurrent cervical cancer. So after that came the question, now, can we potentially introduce immunotherapy in the recurrent setting? And of course, this was a landmark study by Nicoletta Colombo, another keynote study that included pembrolizumab in that setting. And then this brought an additional standard of therapy. So now patients undergoing treatment for recurrent disease in the Keynote 826 study showed that if you had the combination of platinum, paclitaxel, bevacizumab, and pembrolizumab, that then there would be a benefit to those patients. And then generally, that's the standard approach. And particularly patients who have PD-L1 positive tumors, that is typically the approach for those patients. And then most recently, of course, obviously, in the setting where patients fail the Keynote 826 regimen that I just outlined, what are some of the other novel innovations? This is a study by Rob Coleman, GOG 3023, the Innova TV204 trial that introduced an antibody-drug conjugate, tisotumab vedotin, where the response rates were actually quite favorable in a very unfavorable population. 24% response rates, complete plus partial, and certainly up to 70% stable disease or clinical benefit setting in a setting of recurrent platinum-resistant cervical cancer, which I think is certainly impressive. And of course, obviously has brought another option for patients with recurrent cervical cancer. So obviously, then now moving on to the most common type of cancer in women here in the United States, at least, is endometrial cancer. There's no doubt that obviously now endometrial cancer is a disease where there is a significant reliance on the molecular profiling of these tumors, and this is the landmark study that led to the molecular identification of the subtypes of endometrial cancer that now derives a great deal of impact in how we make decisions about the treatment. The PORTEC-3 trial was a landmark study as well, where now we were asking, can we actually add chemotherapy to the standard pelvic radiation plus chemotherapy in patients that have high-risk disease? So high-risk endometrial cancer, stage 2, 3s, high-risk histologies like serous or clear cell. And basically, that study showed that there was a benefit to the addition of chemotherapy. So typically now, patients who undergo treatment for high-risk endometrial cancer, we provide the combination of chemoradiation followed by chemotherapy. As I mentioned before, molecular profiling for these tumors is very, very important. And there was a study, of course, obviously the Keynote 775 that looked at a tyrosine kinase inhibitor plus an immunotherapy in patients with advanced endometrial cancer, particularly in patients with MMR mismatch repair proficient population, where this now became a new standard with the introduction of novel therapeutics into the arena of recurrent or advanced endometrial cancer. And then, of course, obviously, the most recent developments have been the definite introduction of immunotherapy into the treatment of patients with advanced or recurrent endometrial cancer. This is the study GOG 018, and then subsequently the RUBY trial, where we saw the introduction of pembrolizumab and the introduction of the dostarlimab in patients with recurrent or advanced endometrial cancer, that now that has become the standard of care, and it will be very unusual for a patient in the United States with this disease not to have immunotherapy included in their realm of therapeutic options. Now, in terms of surgical trials for endometrial cancer, of course, as I mentioned previously, prior to the LAC trial, we had the question on the surgical approach to patients with endometrial cancer, that being open versus laparoscopic surgery at that time. And this was the study by Joan Walker, which was the GOG Lab 2 study. And that was a study that really set the standard moving forward with regards to how we approach patients with endometrial cancer. That was a study where the results show that minimally invasive surgery was not inferior. So in other words, that we can safely proceed and recommend to patients that a laparoscopic hysterectomy and bilateral salpingo-oophorectomy, and at that time, lymphadenectomy, was the standard of care for these patients. A subsequent second study, this was the LACE trial by Andreas Obermeier, also asked the same question, open versus laparoscopic approach. At that time, there was not a robotics approach in minimally invasive surgery. And again, this was a confirmatory trial that basically showed that, yes, we should proceed and recommend a minimally invasive approach to patients with endometrial cancer. And that till this day remains the standard recommendation for a patient with endometrial cancer. The ideal approach is a laparoscopic or now robotic hysterectomy. For many years, as I mentioned, the assessment of the extent of the disease was not just the hysterectomy, but also a full lymphadenectomy. Of course, a full lymphadenectomy of the pelvis, the periaortic area. We know that there was a significant risk associated with these procedures, not only intraoperatively, but potentially also postoperatively. So then the thought then came to the area of endometrial cancer, as it had previously in melanoma, in breast cancer, in vulvar cancer, that we should explore the principle of sentinel lymph node mapping. So this was a landmark study, the Senti-Endos trial published in Lancet Oncology in 2011. So now already, 14 years that sentinel lymph node mapping has become the standard of care in patients with endometrial cancer. For many years, we were using blue. In many countries, they still use the blue dye for identification of sentinel lymph nodes. But we know that the better tracer is indocyanine green, and that's used both in laparoscopy or in robotics. And that data came out of a very important study that was published in Lancet Oncology in 2017 by Emma Rossi and their team, and it's called the FIRES trial. And in that study, basically, it was demonstrated that indocyanine green was an ideal component and a tracer for the evaluation of sentinel lymph nodes. And then to this day now, routinely, because most cases in the United States of endometrial cancer are done robotically, then ICG has become a standard because that is a technology that is integrated into the robotic system. But even in laparoscopy, ICG is still a standard for us in the setting of sentinel lymph node mapping. So then now moving on to ovarian cancer, and of course, obviously, there have been critical trials in the setting of surgery and in the setting of therapeutics. Lots of studies in the setting of therapeutics. So of course, obviously, I will go through what I think are some of the most impacting and practice changing. But as you are all knowing, the patient with ovarian cancer typically is a patient that presents with advanced stage disease. So these are patients where we're trying to determine, do we go to surgery first, followed by chemotherapy, or do we do chemotherapy first, followed by surgery? So you are all familiar with the multiple studies that have explored this question. And certainly this is a question that has continued to be pursued study after study. Initially, the EORTC trial by Ignace Vergote asked, what are the outcomes if we do surgery followed by chemo versus if we do chemo followed by surgery followed by additional chemo? And the expectation was that surgery was going to be better because that's what the retrospective data has shown us. But this study showed us otherwise. This study showed us that there was no difference. So, of course, many, and particularly those who advocated for surgery, were very critical of the study, suggesting that, well, perhaps you saw no difference because the surgery was not really great surgery, so we should do another study. So then there was a second study that was done asking exactly the same question, and the results were exactly the same. There was no difference between one approach or the other. So then, of course, there were many critics to that second study who said, well, maybe it's not just bad surgery, but actually the chemotherapy that was used was not ideal. And the patient population that was entered was not ideal because there were just many elderly patients. So then, therefore, we should do a third study. A third study is conducted. As we know, the results were the same. So, of course, what do? A fourth study that again looks at exactly the same question, and we get exactly the same answer. So you would think that in the field of gynecologic oncology, after 4 studies, prospective, randomized, tell you that there is no difference, that we would assume that obviously that there is no difference, that we would already have data showing us and confirming that there is no difference. But instead, what does the field do? They say, let's do a 5th study. And this study, coincidentally, was called the TRUST because the investigators in that study said, we don't trust the other 4 studies. So then this study is going to be done only by select surgeons, surgeons who qualify as really skilled surgeons, surgeons that really know how to do this surgery in centers that are really dedicated centers. And I love when they say an expert center, but anytime you ask somebody, can you give me the objective definition of what is an expert center? everybody kind of starts babbling like blah blah blah, blah. So again, this was the study by presumably the master surgeons. So the study again question: do we do surgery first, followed by chemo, versus chemo followed by surgery, followed by additional chemo? The primary endpoint was overall survival. So, fifth study looking at this question with the presumably great surgeons, no difference. So again, another definitive study suggesting that it is about patient selection. There are some patients, yes, who are ideal candidates for surgery first, but there are others that will benefit from neoadjuvant chemotherapy. So in that study, what was concluded, and again, this is a study that was just presented at ASCO, hasn't been published yet. The primary endpoint of the study was not met. In other words, there was no difference in overall survival. And of course, the authors of the study, being favoring of the surgical approach, they said, oh, well, wait, forget about the primary endpoint overall survival. Look, there was a benefit in median progression-free survival. So then therefore, there's still some hope for surgery first. Again, I think it's about selecting the appropriate patient population. Another question that was asked in the last decade was, should we do an extensive lymphadenectomy in the setting of advanced ovarian cancer? So this was the Lions trial, also published in the New England Journal of Medicine by Philip Harder and their group. And basically, patients were randomized to full cytoreduction and lymphadenectomy versus just cytoreduction. And the answer was there's no difference. So then, therefore, today it will be very rare that anyone would undergo a routine lymphadenectomy in the setting of advanced ovarian cancer. The second landmark trial that I also like to address with regards to the recent impacting trials in surgery is this one on, or the second theme is this one on recurrent disease. Because for many years, the thought was in recurrent ovarian cancer, we should operate, right? I mean, just like we do in the upfront, we should operate in the recurrent setting. So there was always this debate as to like, what do we do in the recurrent setting? So this was a study published by Rob Coleman, GOG 213, that basically looked at surgery versus chemotherapy. So patients either go into surgery at the time of recurrence or chemotherapy. And what he found was that there was no difference in progression-free survival or overall survival. So again, kind of following the same theme, a number of investigators said, well, wait a minute, we don't trust that study. Let's do another one. So interestingly, actually, in this case, this was the Desktop 3 trial and also published in New England Journal of Medicine. And in this study, there was a difference in favor of surgery. However, what we learned from that study was that these patients were treated with a different type of chemotherapy regimen if they got chemotherapy. So in GOG 213, patients received carboplatin, paclitaxel, and bevacizumab. In this trial, there was no bevacizumab. So one of the first suggestions about these outcomes was, if you have bevacizumab to offer your patients, it doesn't matter if you do surgery or go straight to chemo and bevacizumab, the outcomes are going to be the same. The other thing that we learned about these studies was that in this one, in the Desktop 3, where they showed a benefit was if you achieve optimal cytoreduction, meaning if you leave no residual disease, surgery is of benefit. However, if you leave residual disease, your outcome is actually worse than chemotherapy. So then the question is, if you are going to opt for surgery, how are you certain that you're going to get to no residual disease? So in other words, if you're going to go for it, you really should be sure that you're going to be able to get no residual disease, because otherwise you're doing a disservice to that patient. They should have gone straight to chemotherapy. And then lastly, medical therapeutics, and I think this is where major advances have been made in the setting of advanced ovarian cancer. This is the SOLO-1 trial. I think everyone is familiar with this study. And this was a study where the addition of a PARP inhibitor, olaparib or Lynparza, was associated with a 70% reduction in recurrence in patients who were BRCA positive. So after the solo one, any patient with BRCA positive mutation, typically after completion of their upfront treatment, after completion of surgery and chemotherapy, or chemotherapy, surgery, chemotherapy, if you were BRCA positive, then you received the PARP inhibitor as a standard treatment. The question then came up, well, what about if you are BRCA negative? And what about if you're HRD negative? Because it was also shown that in patients who are BRCA negative, but HRD positive, they still benefit from a PARP. But Antonio Gonzalez in the PRIMA trial basically asked, well, does a PARP help everybody? And the answer from that study was that yes, even in the setting, not as much, but even in the setting of HRD negative, BRCA negative, HRD negative, that those patients would derive a benefit. And then subsequently, the question came up in the Paola trial with regards to how about adding bevacizumab and PARP to the maintenance regimen. And for patients who have been on bevacizumab, then certainly there was a benefit in adding a PARP inhibitor to that population. So if a patient now has been getting treatment with platinum, taxane, and bevacizumab, then typically the recommendation is to continue with that regimen as well. Now, in the setting of recurrent ovarian cancer, this was a study that also looked at, this is a follow-up of the SOLO one. This is the SOLO 2 trial. Platinum-sensitive patients respond to chemotherapy. The question was, well, if we are adding a PARP in the setting of the upfront, when the patients have no disease, when the patients recur and they get back to no disease, is there a benefit to adding a PARP inhibitor? And then generally, this is a recommendation that is given to most patients that are in that setting after the results of the SOLO 2 trial. Certainly, there was a benefit in overall survival in that population. This is one of the other exciting trials because platinum-resistant patients up until now really had very low likelihood of response. I mean, response rates in the 5 to 15 range. So now the SORAYA trial is a trial that looks at the folate receptor alpha positive patients. Overwhelming majority of patients with ovarian cancer are folate receptor positive. And in that setting, the patients have derived the benefit. It's certainly a 24% benefit in terms of response rates, clinical benefit even higher because, of course, a stable disease counting as a clinical benefit. And frankly, on the patients that I've had on mirvetuximab, I think the patients tolerate the treatment quite well. And then lastly, this is a very recent publication. We're actually going to have a podcast in our journal. We have weekly podcasts in the International Journal of Gynecological Cancer, the ROSELLA trial. And the ROSELLA trial basically explored in the platinum-resistant setting a anti-glucocorticoid medication called relacorilant in combination with nab-paclitaxel, so Abraxane, versus Abraxane alone. And what they found was that certainly, at least in the progression-free survival, there was a distinctive benefit. And of course, obviously, there's still time awaiting for maturity of the trial for overall survival. But this seems to be also another exciting option for patients in the recurrent platinum-resistant setting, where, again, this is something that just a few years ago, the word exciting never went with platinum-resistant ovarian cancer. So now this is something that we're really looking forward to, hopefully integrating this in the treatment of our patients. So in conclusion, for cervical cancer, surgical de-escalation is a highlight of what we do today. Patients not getting radical hysterectomy in every single setting, conization, simple hysterectomy being part of that de-escalation. Combination therapies in the advanced and recurrent setting, adding pembrolizumab, adding antibody drug conjugates has really brought new options for our patients. Endometrial cancer, I think we have clear and definitive evidence that the minimally invasive approach is how we should proceed in terms of doing surgery for those patients. Sentinel lymph node is the standard of care in our country, at least. And immunotherapy definitely is a key component in the recurrent and metastatic disease. For ovarian cancer, again, there's an increasing use of neoadjuvant chemotherapy. Some have asked, well, how often are you using neoadjuvant chemotherapy now? Not just here at Methodist, but throughout the country, there's already publications where on average, anywhere from 70 to 85% of patients with advanced ovarian cancer undergo neoadjuvant chemotherapy first and then surgery after that. And, certainly, obviously, surgery in the recurrent setting, surgery in select patients. Which patients? Typically, patients with a single site of disease, ideally a patient that has had a recurrence more than a year after completing therapy. Those are the ones that we see as ideal candidates. And then, of course, obviously, both in the advanced and the recurrent setting, PARP as a standard in the majority of patients. And then, as I mentioned, novel therapeutics, very, very promising in platinum-resistant patients. So with that, I hope you have gained some information and knowledge as to what have been the most impacting studies in the last decade in gynecologic oncology. Thank you again for this opportunity. Always very honored to work with our global team, and happy to entertain any questions that you might have.
Thank you, Dr. Ramirez. We've gotten some questions about asking for links to the studies, and we'll certainly look into that. We'll certainly
Yeah.
share the recording as well. As we wait for some more questions to come in, as you're able to, would love to just hear a little bit about the current research that you and your team are working on now. What's of interest to you? What is your team focused on?
Yeah, well, thank you very much. And yes, I mean, well, happy to share these slides with anyone who might be interested. In terms of the research, obviously when I started here at Methodist in May of 2023, and one of my missions was to expand our research portfolio in gynecologic oncology. When I started, we had 3 prospective studies in gynecologic oncology. Today, we have 25 prospective studies in gynecologic oncology. And certainly for us, it's been exciting to partner with cooperative groups to introduce novel therapeutics into the management of patients with cervix cancer, endometrial cancer, ovarian cancer, because certainly there have been, as I mentioned, a number of advances, but there's a lot of other very interesting novel therapeutics as it pertains to antibody drug conjugates, as it pertains to target in the immune microenvironment of the tumor, that are very exciting. And we are taking part in many of those studies in the setting of all of these diseases. We also have investigator-initiated studies. So that means we're not bringing in studies from cooperative groups, but these are studies that we're initiating out of Houston Methodist. And one of the points that I think is most exciting now is in the setting of patients with ovarian cancer. And that is particularly looking at something that most in the audience, I'm sure, are familiar with, is circulating tumor DNA. It's something that many patients now will ask you and have questions as to how are we using circulating tumor DNA. So in the past, in patients with ovarian cancer, after they completed their treatment, generally was imaging and just a tumor marker, a CA-125. And of course, obviously now we integrate maintenance therapy, but in terms of the assessment of their disease, we still are restricted to imaging and CA-125s. So now with circulating tumor DNA, we're able to actually go to that level of granularity, to the actual DNA of tumor. And we're able to detect in the blood whether there are any remnants of that DNA from the tumor that are circulating around the body. So this is when you have a normal CA-125, you have a normal scan, and for some reason your circulating tumor DNA is positive. What does that mean? In other words, is this going to be a tool that we can use to detect a recurrence even earlier? is this going to be a tool that we're going to be able to use to be able to guide our practice in terms of those patients that finish their treatment? They're very happy with the results of the scans. Scans are negative, markers are negative, but wait, your circulating tumor DNA is still positive. So then what do we do with those patients? So it's exciting. It's exciting to see what we can potentially develop from that. Obviously, as with any innovation, the issue that often comes up is, well, is the innovation ahead of the action that you can take? So for many patients, as I had recently, a patient where she's following on surveillance, and she completed her therapy a year ago, and her imaging is negative. Her CA-125 is negative. She feels great. And her circulating tumor DNA have been negative, 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 positive now. And then she's like, oh my God, that means it's coming. But what do you do at that point? Because we don't really have studies yet that tell us that starting treatment at that point is going to impact the outcome for that patient. So oftentimes, a lot of this new information, yes, is wonderful, but it also adds some level of anxiety for some patients, because it's like, but you're getting this test and now it's positive, but you're not doing anything about it. So what do we like? How do we move forward? So I think that, it's exciting to see all of these things that are evolving, and we're being part of it. And we'll see how this ultimately contributes to our management of our patients.
Right. A question from a guest. It says, do you think radical hysterectomy for cervical should be considered obsolete in the presence of radiation therapy?
That's a very good question. Interesting question also. So, as you know, radical hysterectomy beyond 4 centimeters is not recommended, unless you're in a setting where there's absolutely no access to chemo radiation. So, as we look at it in the algorithm, is more than 4 centimeters, chemo radiation. Now, less than 2 centimeters, provided meeting criteria of the SHAPE trial, you basically are recommending a simple hysterectomy. So in the past, it was from microscopic to 4 centimeters, everybody got a radical. And now you basically are saying, well, it's only from 2 to 4 centimeters. However, this was from a time of measuring tumors by a pelvic exam, basically by manual examination. Some imaging as well, but now we're getting such good imaging that when we often say, well, this tumor is 3 centimeters or 3.5 centimeters, you get imaging, it shows you that it's actually 4.2. So in some centers, they're actually looking at anyone with a tumor greater than 3 centimeters getting chemo radiation. So then you're basically making it less and less and less indications. So basically, by doing so, you're saying you're only getting a radical between 2 and 3 centimeters. So will it be obsolete? Probably not in the near future. But I think as we get more and more savvy about the real size of tumors and the information that we capture from imaging, we're going to be doing less and less radical hysterectomies. And you might say, well, what about in low income countries? I mean, yeah, there may be more because there's not so much access to chemotherapy and radiation. But yeah, it's a very good point.
Great. Well, thank you so much. I think that's one more question, just right under the wire here. It says, Dr. Ramirez, thank you very much for this excellent presentation. I have a question on behalf of one of our local patients in UAE. Do you know any doctor in UAE that specializes in gynecologic oncology, or who would you recommend? So we can follow up on that one, maybe if you
Yeah.
have some recommendations on that.
Yeah, definitely. I
I know
do.
you're
I do
very
have.
well connected around the world.
Yeah, so happy to share those with you. Yep.
Great. Well, thank you all. Thank you for your time this evening. As I shared earlier, it's just an honor and a pleasure to work with Rofaida on these events. And thank you, Dr. Ramirez, for your time and sharing your expertise on the latest in the field. We truly appreciate it. Thank you, everyone.
Thank you so much, Caitlin, for the invitation.
Thank you.